Hello and welcome. I'm Christine Namata. I'm a clinical fellow in intensive care medicine at the University of British Columbia. I'm based in anesthesia and did my training in Uganda. We're going to discuss COVID-19, in particular, what therapies worked and what didn't work. So just a brief outline, we're going to talk a little bit about the intro and epidemiology, which many of you already know, and then the therapies that actually worked, and we'll talk a little bit about those that didn't work and what the current guidelines are on the management of COVID-19 patients. So some of the basics of COVID-19, so SARS-CoV-2, well, virus was identified as SARS-CoV-2 and binds to human respiratory epithelial receptors. That's the angiotensin converting enzyme 2 via the receptor binding domain on the virus. Most of the cases of COVID-19 are mild, fortunately. About 10% will get hospitalized, and of those that are hospitalized, 10% will end up in the ICU. Now, the mortality rate varies from 1 to maybe 2 to 5%. It's very variable depending on location, but definitely those who are admitted to the ICU have a significantly higher mortality, like 30 to 40% in some areas. The variants, and there have been various mutations in the virus itself in just 2 years, right? We've heard of the alpha, beta, and most recently we're dealing with the Delta variant in most parts of the world. This virus was first identified in November, December of 2019 in Wuhan, China, and that's where the index cases were first reported. By early Jan, maybe 5th, WHO declared an outbreak in China of COVID-19. And by the end of that month, the Director General of the WHO declared a public health emergency of international concern because the virus was spreading quite rapidly. And sure enough, by early March, it was at pandemic level. So by the end of September, maybe 28th, cumulative cases were more than 230 million worldwide, with about almost 5 million deaths recorded. And you can see that in just 24 hours on that day, that recorded almost 6,000 deaths from COVID-19. So in terms of therapies, what has actually worked? There have been various studies trying to figure out what we have that can actually help combat this virus when someone gets COVID-19. And we've found a few that have actually helped. So this is a paper published early this year in the New England Journal of Medicine. That's from the recovery trial group in the UK. They looked at patients who got dexamethasone versus usual care, and usual care was no steroid. And those in the dexamethasone group got at least some steroid for at least 3 to 10 days. And you can see that 2,000 patients got dexamethasone, and maybe over 4,000 were in the usual care group. And throughout, you can see that those who got dexamethasone did much better than those who did not. And interestingly, the sicker you were, the more likely you were to benefit from steroids, probably because you had more inflammation going on. But definitely you can see that dexamethasone was a big game changer for us. We had something to work with. So that is one of the definite current standards of care. So dexamethasone does help with COVID-19, but only for those who are on oxygen, I think is the current recommendation. And the sicker they are, the more they need it. The other thing that worked are interleukin-6 inhibitors. That is most commonly tocilizumab and sarilumab. I think most centers use toci. This is a paper from the RIMAP-CAP trial investigators. It's an international collaboration. It's a research group. So they looked at IL-6 receptor antagonists in critically ill patients in particular, those with COVID-19. And you can see that the number of organ support-free days was significantly higher in those who got IL-6 inhibitors and those who did not. So, so treatment with IL-6 inhibitors does improve outcomes. There were some trials before that were not so convincing, and some found negative effects, but this was, at the time of its publication, it was the largest trial. And luckily, shortly after, we got an even bigger trial to help us confirm that evidence. So the recovery collaborative group has been of immense help because it's a very large and adaptive collaboration. In the UK, that's more than 47 NHS centers at which they are recruiting patients to receive various therapies and trying to find out the difference in their outcomes in regards to COVID-19. So this was from a meta-analysis of mortality in randomized controlled trials of TOSI patients with COVID-19. And you can see that those before the RIMAP cap were significantly, very small trials, right? You didn't have a very large sample size. So RIMAP cap had about 353 in the TOSI group, which is quite significant, and 400 in the usual care group. And you can find that they found a mortality benefit that is 28% versus 35%. And then recovery comes along with 2,000 patients in the TOSI group versus, almost equivalent number in the control group. And you can still see a signal for benefit. 31% versus 35%. So in general, so when you look at all trials, there's still some benefit from using interleukin-6 inhibitors. This was tocilizumab in particular. Now, I don't know about its availability back home, but it's something you can add. All we have are immunomodulators right now for patients with severe COVID-19. So steroids definitely, and IL-6 inhibitors. And recovery trials showed that using steroids and IL-6 inhibitors is much better than using either alone. So the benefit is in addition to that with seen with giving steroids alone. Then there was remdesivir. The WHO had a collaborative group, research group, that is the Solidarity Trial Group. And this, various member states of the WHO, they looked at 4 repurposed drugs to see if they had any effect on mortality from COVID-19, and that included remdesivir. Now, from their findings, there was little or no effect on hospitalized patients with COVID-19. However, there were some trials that were published. I think this was the ACT-1 trial that was also looking at remdesivir in COVID-19, and they found that it was superior to placebo in terms of shortening time to recovery. So currently, the recovery trial was still also recruiting patients into the remdesivir group to try and sort of come up with a final decision on remdesivir. Currently, it's only recommended for use. It's been shown to help those who are on a little bit of oxygen, but not really on organ support. So once patients make it to the ICU, REM is really not going to do anything. So currently, it's not recommended for those who are on organ support, but it may help those who are maybe moderate disease, mild to moderate disease, on a little bit of oxygen. And then there were many therapies that did not work, unfortunately, for us. So this was a very disappointing finding. This was a paper published in JAMA in 2020. When the pandemic first broke out, there was a lot of talk about how hydroxychloroquine or chloroquine could be used because it apparently had in vitro antiviral effects. but this didn't really pan out in human trials. There were many RCTs that were done, and they found no benefit from hydroxychloroquine or chloroquine in terms of COVID-19 outcomes. And in fact, there was a systematic review that found that using hydroxychloroquine, especially with azithromycin, might actually increase mortality. So it's a definite no-go currently. The WHO and other international guidelines do not recommend using hydroxychloroquine with or without azithromycin for COVID-19. The other thing that didn't work was convalescent plasma. I mean, the science makes sense, but it didn't really translate into tangible results. This was an RCT still from the REMAP-CAP investigators, published in October this year. But I think there was a preprint way before that with a COVID pandemic data, it transmits pretty rapidly. Anyway, convalescent plasma was not found to really help in terms of reducing, in terms of improving organ support free days for patients with COVID-19 in the ICU, or generally critically ill patients with COVID-19. So there's very low likelihood of providing any meaningful improvement. And actually, this trial was actually stopped early due to futility, believe it or not. They started the REMAP-CAP, they started recruitment in, I think, November of 2020. But then by maybe 3 months later, they had more than 2,000 patients enrolled into that group, and there was really no benefit. So it was stopped very early because there was nothing to support its use. So next was ivermectin. Well, currently the guidelines do not recommend ivermectin use except in a clinical trial, because the data we have so far has not really provided any evidence for its benefit, let's say. It doesn't improve mortality or COVID-19 related outcomes. So the current recommendation, at least from the IDSA and NIH and WHO, most of these are really in agreement, is that should not use ivermectin for COVID-19 patients in hospital unless they're enrolled in some clinical trial that's been authorized. So the other thing that didn't really work that well was colchicine. I mean, it helps for, very mild COVID that's in community-based, cases. In terms of reducing probability of hospital admission and composite of death as a result. And this is from the Corona trial. It was a trial, I think, based in Montreal, but very multi-center, various parts of the world. And they found that in patients at community level, there was some improvement, but in terms of clinical related events, especially in hospital, there was really no benefit. And in March of this year, recovery trial closed recruitment to colchicine treatment because they found no effect on COVID-19 related outcomes. So there's still some other studies that are in the pipelines. For example, the WHO launched a Solidarity Plus trial as a follow-up to the Solidarity trial. And they're looking at 3 repurposed drugs now, including artesunate, which is a common antiviral we use back home for severe malaria. So I'm very interested to find out what this will reveal. And this was started just mid-year. So I think we have something to look forward to. We'll see what happens with that. And then there's other drugs that have recently been added to the guidelines, monoclonal antibodies in particular, but it's still a conditional recommendation because they only work in seronegative patients, meaning you need to have a test a point of care test for patients who are critically ill to see, or who are hospitalized to see whether they are seropositive or seronegative, have been vaccinated or not. So that kind of thing. And they're mostly recommended for, unvaccinated, elderly, multiple comorbidities at high risk of progression to severe disease. But about in regards to its availability back home, it's probably not yet very available. Currently in Canada, it's not yet part of the guidelines because there's still a lot of things that we feel are still up in the air, but they're being used in the US and in some other centers. So in summary, what worked? This is from the IDSA, but it's really similar to guidelines from Surviving Sepsis Campaign and WHO. So hospitalized patients, but not on oxygen, don't really need dexamethasone. Once they get onto oxygen, then yeah, dexamethasone does help. You may add remdesivir if it's just a little bit of oxygen, that could help. And as per the most recent guidelines of last month, if they're at high risk for progression, you may give them monoclonal antibodies. They have quite complicated names. I think it's casirivimab and something like that. And then for hospitalized and requiring high flow or NIV, definitely dexamethasone. So typically this is when patients get admitted to the ICU, that it's on high flow, NIV, or on mechanical ventilation stroke ECMO. So that is when patients definitely need dexamethasone, and then you pull out your IL-6 inhibitors. For those who are seronegative, apparently you may, depending on where you are, use monoclonal antibodies or not. They might help reduce your duration of mechanical ventilation and improve your outcomes. But definitely the only thing we have so far are immunomodulating agents. We don't have anything against the virus per se. So it's still an uphill battle for us with all these variants coming up. And then definitely for patients with ECMO, still I think dexamethasone and tocilizumab are worth a shot. So in summary, the death toll continues to rise, unfortunately, and we still have very limited therapeutic options in terms of managing COVID-19 patients, mostly IL-6 inhibitors, steroids, and now maybe some monoclonal antibodies. Prevention is still key, so vaccinate, social distance, and infection prevention and control measures, especially in hospital, hand hygiene, even at home. So, and then of course, quality supportive care is paramount, because I mean, if the only thing we can do is modulate the immune response, then what we're left with is mostly supportive care, right? So proning still works as for any other form of ARDS. Paralysis when needed, sedation, and renal replacement therapy when needed, trying to prevent that. But it's definitely supportive care that makes a big bulk of their care, even in the ICU. Thank you very much for listening. Questions or comments are very welcome. Thank you.